Thank you, members, to our additional meeting of the Health Committee this week. And this afternoon we're receiving a briefing from the Royal College of GP, NNA and the BMA GP Committee. The briefing today, members, is focusing on the winter surge pressures on GP services, and we have a number of briefings over the next few meetings focusing in on the winter pressures that we're all seeing taking place out there. I refer members to your papers at tab 2 of your pack, which include a copy of the Minister's written statement on winter preparedness and winter surge plans at tab 2.2 and copies of the Trust delivery plans at tabs 2.3 to 2.9. So I'd now like to welcome by Starleaf, first of all, Dr. Lawrence Dorman, who is Chair of RCGP-NA. Are you able to hear me okay there, Dr. Dorman?
Yes, I am, Chair, thank you.
Yeah, thank you. And also by Dr. Alan Stout, who is Chair of BMA NIGP Committee. Can you hear me there okay, Dr. Stout?
I can, Chair, thank you.
Okay. Well, listen, thank you both very much for attending today. Obviously, it's an issue of some concern to members, but so we're looking forward to the session with yourselves in relation to the pressures that are currently being experienced by yourselves, and also the issue of access to GP services and all of that. So I'll go back to maybe you, Lawrence, just to check. Do you want to lead off on remarks, and then
yes,
I'll go to Alan? And then...
Yes, please, Chair. Thank you. I'll lead off here, and then Alan will talk about it. We'll keep it fairly brief because we want to take questions from you. So, Chair and members, thank you both. Thank you all for inviting Alan and myself to present to the Health Committee this afternoon. Unfortunately, all too often, discourse about winter pressures focuses disproportionately on hospital colleagues, so your invitation to us to represent general practice is extremely welcome. The last time I was here at committee, I shared how busy our surgeries were and how demoralised and exhausted our staff were. And unfortunately, this is still very much the case, and we're genuinely fearful of what the winter period will bring in terms of pressure and how we can continue to provide patient care. Put it simply, our GP practices are dealing with a completely unmanageable level of demand. Our latest figures from the 21st of October show that 233,000 patient consultations are happening per week in general practice, 51% of which are face-to-face. Across Northern Ireland, GP colleagues are treating COVID-positive patients safely in the community. We're managing the impact of escalating waiting lists, we're rolling out a complex vaccination programme, all while maintaining routine patient care. We are also involved significantly in teaching and training undergraduate medical students who will be the future doctors of tomorrow. And in addition to this, enhanced GP roles such as elective care work, which has performed over 25,000 procedures for the past 2 years. It's a mammoth task, and in any other situation it would be simply undoable. And let me be frank when I say, if it wasn't for the tireless work, the long hours and sheer dedication of our colleagues, I'm quite certain that some of our GP practices would have folded. It's vital we do not lose these practices. These practices are unique teams and are an essential part of our healthcare system. They are hugely valued by their communities and are frequently a central focus for their well-being needs. Once lost, their unique patient knowledge, which extends back generations, will be gone forever, and the ripples from this will be massive throughout our healthcare system. Time and again, we see dedication and flexibility from our GP practices. Thousands of COVID boosters have been administered during the last month during weekend clinics. All of these have been done outside surgery hours to ensure that infection control requirements are met, a 15-minute post-vaccine wait as necessitated by the manufacturers, and we have minimised waste. It's worth noting that at the start of COVID vaccination, government was advised that 20% wastage would have been the normal for a vaccination programme. Our CMO wisely challenged to reduce this by half to 10%, whereas general practices delivered less than 10% waste. Most importantly, by doing these clinics over in weekend hours, we have kept our GMS services open. We haven't stopped anything. I appreciate sincerely that as elected representatives, many of you will have heard from your constituents that you are struggling to access our services. As a GP leader, I deeply regret that, but we must take these difficulties into context. We simply cannot meet the demand for our services with our current workforce. As we continue to comply with government-mandated infection control, we've had to operate our services on an initial remote basis, but our technology is frequently not fit for purpose, and we lack the resource to answer the number of calls we receive. Some practices are using outdated phone systems that simply aren't equipped for the high volume of calls, and targeted investment to upgrade our digital infrastructure in practices is vital and could go some way to improve our patient experience. We would very much appreciate your support as we continue to make the case for this investment. Fundamentally, though, it's important to remember that the demand for GP services is infinitely higher than we can supply. So short-term measures such as winter pressure fundings are helpful and needed and will provide some immediate and much-needed relief for our colleagues. But what we really need is more GPs in our workforce and a significant investment in primary care, including the full rollout of the multidisciplinary team model into general practice. Like never before, we need your help to ensure the story is heard accurately. Our health and social care service must work together and must not seek to blame each other. This would just simply be destructive. No one is slacking in our healthcare system. We are all working harder than ever. Please remember, it's not just unprecedented hospital pressures we are facing, but hospital and GP pressures. For example, today I'm covering my partner who has a family issue, so I was due to come in from home from routine work, but unfortunately I'm having to isolate and work from home because my daughter's contracted COVID. But as a GP partner, I will innovate, I will work from home, and I will do everything I can to serve my patients. So I'm using a Health and Social Care Board laptop and using my own personal mobile phone, which has enabled me to meet my patients' needs as best I can. Because I'm working in a partnership model, my colleagues will not see me stuck, and likewise for them, I will do the utmost for them if we have problems. Every week, Alan and I hear from GPs and practice team members who have broken down and had to take necessary sick leave because of their stress at work. A local practice close to me lost 4 frontline staff members in 1 month alone, all citing abuse received at work. Another practice I am aware of has experienced 6 out of 7 reception staff handing in their notice, all having had enough of a constant barrage of abuse on the telephone. The abuse of GPs and our staff is indefensible, and it makes a significant and detrimental impact to our workforce. So like me, practices are struggling to keep their services running. Some have had colleagues off due to sickness, some have had them off due to COVID, and some due to significant personal medical diagnosis. We're doing our best, but criticism in the press, media and social media sometimes implies we're not working hard enough. This could not be further from the truth. Many of the colleagues I speak to speak of genuine fear that the number of patients they are providing consultations for, and remember when we speak on the telephone, this is a consultation which carries a significant professional risk. It does not feel safe, and many other practices describe being one team member sickness away from collapse. So innovative interventions such as the federation-based rescue practice team, which provides support for struggling practices, must be invested in if we are to prevent practice closures. This current scheme has witnessed a marked increase in demand for its services due to COVID. As of the start of this month, on the 5th of November, 54 practices were availing of services, but since in the 2 weeks, another 5 practices have formally requested for its help. So we would be grateful if you could urge the department to invest in schemes like this, which provides some support, but more importantly, solutions to resolve problems in practices. The next number of weeks are going to be incredibly challenging for every part of our health service, and the only way we're going to make it through is by working together with support from you as our elected representatives. Your support is very much appreciated, and I look forward to taking some questions. So over to you, Alan.
Okay, thanks very much, Lawrence, and thank you, Chair, for inviting us here today. Lawrence has covered an awful lot in what he said, and I have no intention of repeating all of that, but I wanted to actually start just by thanking you, Chair, and also your Deputy Chair, Pam Cameron, for the very active interest that you have taken in primary care and in general practice in particular. And I know from site visits, including to my own practice, and it is so important to us that you are able to see on the ground and see in real life the pressures that are being felt and the difficulties that we have, and also the messages of support that have come out of those visits have been so welcome to our practices, and you just simply cannot underestimate those messages and what they see, and that in itself is a huge morale boost. As I say, Lawrence has covered this very, very well already, and I'm going to very simply divide it into what we have done well and what we are really struggling with. And I'll just give you a very simple list of both, and hopefully that will lead to questions and discussion. And what we have done well is, first and we have stayed open. Lawrence has told us about the difficulties that we are hearing day and daily from so many practices, but amazingly, we have not had a practice close during the pandemic period. That is credit to all of our GPs, all of our practice teams, but also very importantly to our colleagues that we've worked very closely with in both the board and the department, who have been extremely supportive in all ways to try and free up practices and try and enable them to stay open. So I'd like to record my thanks to them. Not only have we stayed open, but we've also staffed our COVID-19 centres, which have provided a separate resource using the same staff to see patients in primary care who are either COVID positive or suspect themselves to be COVID positive, and that has enabled our practices to stay open, clean and safe, and I know that we've discussed that previously. Again, Lawrence reflected on the numbers that are coming through, which are just phenomenal. We have over 10% of our population contacting us every single week. Our contacts range from between 200,000 to 230,000 contacts per week. Nearly 50% of those patients are converted to face-to-face consultations. That works out at 20,000 per day being seen face-to-face in general practice. And this is quite astonishing numbers. It is an increase of about 20% on previous numbers. Even within this, patient satisfaction is extremely high, and the PCC did their own survey recently, which showed that 80% of patients are happy whenever they are seen, when they contact their practice and they are dealt with appropriately. So we still have very, very high patient satisfaction rates. But again, you cannot underestimate that we are or underemphasize that we are dealing with absolutely everything. We are the first point of contact for patients. We are estimating at the moment that we're seeing 20% of our contacts are patients that have recycled through secondary care, either from complex discharges or from the ever-increasing waiting lists and the inability to be seen, treated, and finally dealt with elsewhere. We're also seeing COVID and non-COVID. We're seeing increasing complexity, particularly with our ageing population and everything else that's going on. And we also, and when you see any message in the press, it nearly always ends with, if in doubt, speak to your GP. And we see the tail of that with every single request coming through us, be that for forms, be it for medical records, be it for advice, be it for various pieces of information that you need for the apps or whatever. That all tends to cycle through general practice. The other thing that we've done well is the MDTs, and those have shown a really successful rollout in the early stages. There was some talk a number of months ago about a reduced number of mental health referrals through the pandemic. That was seen initially as a negative, but actually it's a positive. And what it shows is the value of a primary care multidisciplinary team dealing with a wide range of patients at source, and that reduces the need for onward referral and dependence on secondary care services. Again, Lawrence has covered the vaccination programme, first, second booster flu vaccines, very low waste, and again, on top of our normal work. And also, it is really, really important to emphasise the additional work that's going on through general practice, and that is our Federation services. 30,000 patients now seen in the elective care services. And I'm saying that as an example of how a really strong, vibrant primary care actually acts as a solution to so many of the problems that we see elsewhere in the health service. So 30,000 patients that otherwise would have been referrals have now been dealt with in primary care alternatives to referrals. So again, and just to be brief and to move on to questions, what are we struggling with? Staff, capacity and GPs. The one thing that you can't give us, we can ask as much as we want, you cannot give us more GPs, we need more GPs. Somehow we need to retain our existing GPs, we need to encourage our younger GPs to come, or our younger doctors to come into general practice, but that needs to be a short, a medium and a long-term strategy. But we need staff and capacity as well. We need the MDT rollout. As I say, it's been very successful so far, but the success is created in an equity, and we still have over half of our area and over half of our population still are not served by an MDT, and that is creating increasing problems. We also need infrastructure, and infrastructure means buildings, and it means telephony, and it means IT, and all of those are important in terms of the access and in terms of patient satisfaction and patient contacting. And we need your help with messaging, and we need that quickly because it is so demoralising to our practices. It is so demoralising to our staff whenever they are working so hard, whenever they are working in such an unsafe and an unsatisfactory environment, to hear that constant barrage of criticism. And again, I'm going to reflect the difference between local and national. We are exceptionally lucky, and we recognise that we have a very, very good health board. We have a very, very good Department of Health and huge support. And we have very, very good politicians who have given us a lot of support. We also have good local press who don't jump on the bandwagon of criticising general practice, but there is no question that we are impacted by a lot of the dialogue and a lot of the national press, which then impacts on us, and that's not to mention social media as well. And again, just to finish, and Lawrence finished with exactly the same, we cannot allow our system to get caught up in the clamour to save hospitals and to save acute. We have to have, and Delivering Together describes this very, very well, we have to have that strong foundation in primary care, and that's how we build a health service as a whole that is fit for the future. So thank you, Chair, for your time, and we are very happy to take any and as many questions as you want.
Okay, thank you both, and I'll go to questions then as quickly as possible. I do want to acknowledge what you have said there in relation to the pressure that GP services are under, and I think the committee does recognise that this is an extremely difficult situation. We are in the midst of a health crisis. We are seeing the results of underinvestment potentially in previous years, waiting lists, extensive mental health issues, and all of that then exacerbated and added to as a result of the COVID pandemic. So that is certainly a very difficult environment to be working in, absolutely. In relation to questions, I have, as you know, Alan completed a survey recently and published a report out of the survey, and it had huge pickup. Over 600 people, or almost 600 people responded. And one of the issues that was raised was around the contact in the phone contact system. I did actually a piece of radio this morning, and I quoted a case that I heard just yesterday in my own constituency, where a mother had, prior to dropping or to making a decision on whether she should drop her child off to playgroup with a sore throat, tried to get through to the GP, and 67 calls she made, and she still hasn't got an appointment to date. So my question around that is, I know within the allocation that was made, the winter pressures allocation that was made, and I had been asking for that to be, and I welcome the fact that was done. I know there was also an element of potential investment into phone systems within that. Has that started to take effect, or is that a longer term project? And is there anything more in the short term that can be done while we're waiting for the investment to come through the system? Is there anything more can be done in the short term to address that accessibility at the very first point of contact?
Yes, thanks, Chair. And you're absolutely right. And I know that we've had these conversations before, and they are really important. My heart sinks when I hear examples such as you have just given. And the simple answer to your question is that it is short term. There is things that can be done short term, and there is things that need the medium to long term. A lot of it depends on the contracts. It's amazing how it always comes back to contracts, but the contracts that practices are in terms of their existing phone service. And both Lawrence and myself would be very supportive. I mean, what this has shown us is the weakness of our infrastructure, that we are using outdated and frankly just not acceptable systems, and that includes our phone system. But again, you know that I've said this before, and that I'm very consistent on it, that it is an important part of the answer, but it's not the only part of the answer, because we can't simply address this by creating a fancier queue. Even though that is important, what is vital is that we have people at the end of those phones that are not only able to answer it and to pick up the query from the patient, but also then the staff, which might be a GP, it might be an advanced nurse practitioner, or it might be a physiotherapist, a mental health worker, a social worker, who is able to pick up those different problems. So I think both are really, really important solutions, but we have to make sure that we are addressing both together.
Yeah, and just to add to Alan's comments as well, I mean, there is short-term and long-term things that this can help. One of the short-term things is the use of our data analytics and proper digital telephony could really help practices analyse where the pinch points are in their systems, how we utilise our staff best to the days and the times that are most active. Digital, I mean, includes a whole number of things. So, for example, this morning I was able to do most of my surgery remotely using just a laptop and so on, and that has been so vital throughout the country, and more of that would be great. I'm aware that practices in the West, particularly the Southwest, have been so challenged in places like Lisnaskea and so on, have really benefited, and have even had some locums supporting them using that remote stuff. So there's the digital takes a wider things than just telephone, but you know we just need investment in it. Yeah.
And I'm struck, Alan, by your reference to the issue of information request, and I can imagine that taking up quite a bit of time and causing quite a bit of concern, and also eating into valuable GP time. Is there something more that could be done there, in maybe setting up a helpline or a point of, and widely communicating that out so the public could go directly to the sources of support or information without having to come through yourselves? That strikes me as something that's maybe something we could look at addressing with a bit of imagination. Yeah, Alan?
Yes, sorry, Chair. I think my internet connection.
Do you want me to take it on?
Yes, go ahead, Lawrence, please.
Yeah, so you're quite right, Chair, and we would welcome it. And again, we're conscious that there are groups that were maybe not meeting the needs that we would like to. So people who are applying for HDV medicals and things like that, we are trying to get to them, but we have to concentrate on basically the sick people in front of us. We have to prioritise at the moment. One of the big things we're getting, particularly with the advent of GDPR, is access to patients' notes. And again, we will support them as best as we can. And where appropriate, we ask people to be patient while we deal with these requests. It's just a very difficult time at the moment.
Okay, thank you. Then in relation to, and this is another one that came out very, very clearly in terms of one of the recommendations out of the survey report that we did, was the MDTs. And we're acutely aware of the benefit of the MDTs, but also the fact those have stalled and create the inequality that you have mentioned there and the inequity across the system. Can you update us as to where the continued rollout of MDTs is at present, and are you satisfied with the urgency with which that is being completed? So that's for either of you.
So I'll start here, Alan, if you don't mind. So there is a steering group which is looking at a roadmap at the moment which hasn't been completed.
I'll have to pause there. We're getting a lot of feedback. I suspect it may be from Alan's connection, although Alan is on. Yeah. So we've lost Alan there, but I think that was interfering with the sound. So go ahead then, Lawrence, please. Hopefully we'll get Alan back on.
No problem. We're working constructively to get a roadmap for practices. So MDTs are all practices want MDTs, but there's a considerable amount of work to implement an MDT, and one of those big things is buildings and premises. So we're urging for a roadmap to be finalised. My understanding is that it's nearly complete, and that will really help practices plan ahead for these new members of staff that are coming. As far as we're concerned, it needs to be pressed. Delivering Together suggested that it had to be completed by 2026, and we would urge that deadline is kept to. It is tight, it's ambitious, but I think it's very important. And as you can see, Chair, this reaches out, and part of the reach that we're looking to as well at the moment is to see about deprived communities. So should this be going to some of the most vulnerable parts of our society? And what we have learned from it is the synergistic role between mental health workers and social workers who reach out into these communities, who stop people getting sick or get them whenever at their very early point so that their needs do not escalate, and then takes pressure off the health services. But there is good evidence. We've one MDT area that's out in full, and the evidence from it is showing that it is reducing mental health referrals, it is reducing musculoskeletal referrals, it is making an impact, and it's vital that it's invested in.
Yeah, thank you. And I would support your indication there that those should be targeted to areas where to mend the gaps or fill the gaps as best as possible where services are under particular pressure or have indeed collapsed, as is the case in some of our own, Deborah and my own constituency. Okay, the final one for me then is around the vaccine rollout and booster. The first, second and third vaccines still being requested by people, as well as the booster campaign. Do you believe that there's further support could be leveraged in there in terms of volunteer vaccinators? And I'm speaking in the context of, in the early days of the pandemic, committee here looked at legislation that would allow non-medical staff, and I think that's important so we're not robbing Peter to pay Paul with the system being so stressed. Is there further support can be leveraged to assist GPs in terms of the vaccine rollout?
So I'll pick up on that to begin with, Lawrence, and apologies, Chair, I've changed devices because I think I was getting a lot of feedback on my previous one. You're absolutely right, Chair. I mean, assistance it would be hugely welcome, and we're actually getting assistance as we speak. Partly with the stepping up of the trust centres again, which are going to take a lot of weight off practices, particularly as we move into the different age groups. But also public health have enrolled a lot of administrative support as well. And one of the big feedbacks that we're getting from practices is the labour intensity of actually entering the data onto the vaccine management system. And we know that we are lagging behind in terms of the number of vaccines that have actually been given against the number that are actually recorded. So we know that far more boosters have been given than are showing up at this present time on the system. So that assistance will be greatly welcomed. Both Lawrence and I join the regular vaccination meeting chaired by Patricia Donnelly. And we know that they are looking very actively at taking the pressure off practices from this point onwards in terms of the vaccine programme, because we know and they appreciate just how much of a pressure that has been putting onto our practices, who, again, I think we both covered in our introductions, are actually doing it on top of all of our normal activities as well.
Okay, thank you. So I will go now. We have two of our members participating online there at the minute. So I have an indication from Pam, and then I'm going to Paula, Orlia, Deborah, Jerry and Alan. So Pam, go ahead please if you're there and ready with the question.
Thank you, Chair. Thank you to Dr. Dorman and Dr. Stout. You're very welcome to committee today, and it's good to see you again. I wanted to first of all say how grateful certainly I am and my party are to the work that you have done, not just throughout this pandemic, but through your time in such a really good profession. And we understand it is difficult. The pandemic has been incredibly difficult, and I think the visit to your medical practice, Alan, was very informative and really did show us what the intention of the changes have been, and it was good to see that actually the changes that happened overnight in terms of COVID were actually, in terms of your practice, were actually changes that have been in for 7 years, and they are really changes that are needed in terms of going forward into the future, because we know that the way we were working before was not sustainable, and we do understand that. We understand that there are severe pressures on GPs and on GP staff. So I wanted to thank you for remaining open throughout this pandemic, whilst we're all always inundated with queries and constituencies, and you're continually facing that perception that you're closed. I think it's really important that we do emphasise that GPs are open and have to have to remain open under very strict guidelines in terms of infection control. We do appreciate that and appreciate the work you're doing, and appreciate the vaccine rollout in particular. I had a booster this morning, facilitated by my GP practice here in Antrim, and it was a terrific experience. I've got a very sore arm now, but a very, very smooth running operation where they're using a church hall here in Antrim to administer a booster, and I've no doubt there were a great number of people coming and going from that today, so I can understand that delay in actually updating the records. That's bound to be a pressure. In terms of where we are, as I say, probably the main query will be for all our constituents will be in terms of the access to their GPs and the distress that some people have in not being able to access a face-to-face appointment. So I wondered if you could first of all give us an indication of how those figures have changed from pre-pandemic to now. Has there been an increase in face-to-face appointments in the last year or two? And could you tell us if there is an estimate of how many practices in Northern Ireland which still don't have a telephone or online service for repeat prescriptions? And I'm really interested to hear what's happening with the use of more advanced technology. And in terms of electronic prescribing, where are we? And is there anything particular in terms of resource that could save GPs and their staff, that resource of time and energy in terms of inputting? And I don't know if you, as GPs, are involved in the Encompass programme that the department is still developing, but if you do have any information on that, I'd be interested to hear from you.
Pam, I wonder, could I just ask for an indulgence? I actually had an indication from Paula, and I know she has another meeting to go to. I wonder, could we just go...
That's fine, go ahead.
Okay. So if we can go ahead with those in, I'll come to Paula next. Thank you.
Do you want me to start with that, Alan? If I start, Pam, is that okay? Yeah, thank you, Pam, for that. I really appreciate your comments and appreciate your support for general practice. So taking us back right to the very start of the pandemic, right to April last year, I mean, naturally, we were all very cautious. And again, the ratio of face-to-face appointments to telephone appointments was much lower. So we were trying as much as we could to keep practices safe because we had no vaccines at that stage. But as we've all become more confident in this system, those ratios have increased. So you can see there from our recent figures, it's up to about 50%, whereas at the very start of the pandemic, it was only about 10%. It's important to remember that whenever speaking to a GP on the telephone, that is the start of your consultation. So we're really trying to have a really significant shift in focus where if you speak to your GP on your phone, that's the start of your consultation. It may end in a face-to-face, it may be converted to a direct prescription or an investigation, but it is still a consultation. And we're really trying to get our patients to come with us in this journey. As Alan said before, it took his practice 7 years to get his system right. We've all had to do it in a week. And that it's just understandable that we haven't had the usual co-production, co-design that we would like to have had with our patients while we do these new services, but they will come and we will refine them to a better service for everybody. I'm keen for your support on that. It's really important that we talk about electronic prescribing. We think would be a really, really valuable tool. It would increase safety no end because at the moment we're relying on scripts coming into practices, they're written on paper, whereas a direct, electronic script straight to a practice or to a community pharmacy could make this process much safer and improve the efficiency for patients. Encompass is very interesting, so it is, because it's largely at the moment a hospital systems program, so we're not directly involved at the moment. What we do have is very valuable GP data, and we're really keen that the department could invest in our GP data because we have huge information about patients that's recorded in a system from general practice called GPIP, and we think a very small investment in GPIP could make huge improvements in our system. It would enable researchers to see our healthcare system. It could see where patients enter the hospital system, where they enter general practice. And this could be used for driving health service improvements, but also clinical data, which is very valuable in the modern world. So we think investment in the GPIP in general practice could really help.
Yeah, and just to follow on from Lawrence, and Pam, you quite rightly say, and well remembered, we had been using telephone first for 7 years, way before any of us ever heard of COVID-19. And it is a good example of how you ensure that the right person is seen by the right clinician at the right time. So it means that you can make sure that the people who need the time and need to be seen face-to-face are seen face-to-face and are given that time. And I always use the examples of a complex mental health case or an elderly patient who has multiple medical problems. It's very easy for us to slot them into half-hour appointment as opposed to them trying to cram into 10-minute appointments and everything that entails with that. But it did take us that length of time to get it right. And actually what our experience has shown is that this is the right system. And again, I say this all the time, I never decline, I never refuse, I never debate with anybody whether they're seen face to face. It's actually far more frequent for me and for our practice to be saying to a patient, come down because we really need to see this. And they're actually saying to us, can you not just leave me something on the phone, over the phone, doctor? And so we've ended up with almost the reverse. And again, it just shows that we need that mixed model of consulting. And again, just on the electronic prescribing, that has to be a priority. That's been a priority for the last number of years. I think you have all probably seen in your practices just these bundles and bundles of prescriptions of paper that fires about all over the place. And it's crazy in 2021 that we're still doing this. It would create such a more efficient system for our practices and for our patients if it was electronic. And what it would also do is that it would shift those requests to electronic requests as well, because again, our own practice as an example, we have both systems. So we have a phone line for repeats and we have it available online. And I think we're about 90-10 in terms of the phone being used. So people still just phone in to use it. It's a dedicated line, but we need to.
Thank you, Alan. Sorry, I'll need to move along because we're under pressure of time. Paula, go ahead.
Thank you, gentlemen, for your updates today. I really appreciate it. The first question, just for the brevity here of my questions, but you said, Dr. Dorman, around you need an investment to help with telephony and computer technology. The Minister gave 5.5 million recently there and indicated that 1.7 million of that was to go to this service. Have you got an estimate of how much more you would actually need to bring all GPs up to standard?
No, and as Alan indicated, the problem is that we need to establish exactly what services we have at the moment and what each practice has. So there's 320 individual practices. We suspect probably most with individual telephone contracts. So we would need to assess what our baseline is first before we can move on. So some of this work will have to be done. I apologise, I'm no computer technical expert, but my understanding is that VoIP is going to be necessary as our phone lines and as our digital infrastructure changes in a couple of years' time. So this is going to be necessary work anyway. But telephone lines need to be changed to digital so we can do a lot more with them. And again, this is where we get the digital analytics with it, where we can have more sophisticated call, waiting systems. Although if we've said we don't like people just having fancier queues, it is definitely better if patients have an idea where they are waiting, potentially even with callback functions and so on, rather than just engaged tones. So there is a lot that can be done with this. It's still the start. The 5 million that you're referring to, yes, it was incorporated into part of that, but we think there's a much bigger piece of work that needs to go on throughout the future.
And just to come back on that then, so whose responsibility would it be to conduct that analysis then? Are you going to do that, or do you think that rests with the department to contact all the GPs and get an understanding?
So a survey has been launched already by the Health and Social Care Board, and we're certainly working constructively with them and encouraging GPs to participate with that. I think it's very important that we have that baseline data so that we know exactly what part of the problem is, knowing what you already have before you can invest and bring it up.
Okay, thank you. The other question I was asking was about the booster programme, but I think Colin has already indicated that. But the one thing that will strike me are, you know, where patients have been to yourselves and then you've put into secondary care, red flag referral, whether it's cancer or otherwise. And in the Belfast Trust, we have the public liaison unit, which is fantastic to put in queries. You know, is there any ways that we can, that the department or the Health Social Care Board or the Trust could alleviate some of the pressures that you as GP feel when people come back to say, where am I on the list? Where am I with that red flag referral? I thought I was urgent. You know, is there anything that could be done to alleviate those repeat phone calls who potentially are, you know, not clogging up the phone lines, but, you know, are adding to the pressure?
Yes, certainly we would support, you know, a central booking office. Now, again, I'm not quite sure how that works regionally. Alan could probably fill me in more about how it works around Belfast. But certainly if patients, you know, are enabled, you know, to take responsibility for their own health and they have their own health and care number, whether they can contact a central liaison service that'll let them know exactly where they are in the queue, that would certainly help reduce telephone traffic to our surgeries.
Yeah, and to also just add to that, because it is a really important point, Paula, from the point of referral. So when a patient comes to see myself or Lawrence and we refer them, they are not actually transferred. The responsibility doesn't transfer until they're actually seen. And you're right, because what that does is it keeps the responsibility with the GP, and that hikes the pressure on the GP. And we need to create this environment where we have a shared ownership and a shared responsibility for the outcome of that patient, because that is something that strikes fear in GPs, and it is those suspected cancers that we know need seen quickly. And when we see that they're not being seen quickly, that is massively concerning for us all.
Okay, thank you. I'll leave it there, but thank you.
Thank you, Paula. Orlia?
Yes, so Lawrence and Alan, thanks very much for coming to the committee, and just thank you to all the important work that you are obviously carrying out on a daily basis. It is much appreciated, and I would like to say that you mentioned around some of the staff and GP practices receiving abuse, and I just completely want to condemn that. I think it is just horrible. You know, people are obviously working under really difficult circumstances, and I sincerely hope that it's a small minority of people that they're carrying out that abuse. I know that there obviously is a lot of genuine concerns from, you know, I've received them directly from some of my own constituents, but I can stand over the fact that they haven't in any way been abusive to staff. Now, what they have been, just to say, is extremely disappointed. There was one case that I was dealing with, and a lady rang her practice 286 times. When she got through after 286 calls, she was then told to ring back in 24 hours. And I know that's probably one of the cases that's at the real extreme end, but I think for people that are having that experience and feeling that disappointment, I think that is where people can lose faith in the system. And obviously that's what we want to try and prevent in whatever way that we can support yourselves in doing that. So my question is, and I completely take your points that you are fearful for the upcoming winter period, do you think that the telephone management systems that are in place for each of your surgeries are going to be able to cope this winter?
Yeah, I mean, I'll pick that up first, and I'll give you an honest answer to it. Is no, we aren't confident that they're going to cope. I mean, this is part of the investment, but it is going to take some time. Do you know that example that you give, again, 286 calls? I can't sit here and defend that. Lawrence can't sit here and defend that. I mean, that is not acceptable in anybody's book. And that is a reflection of just how difficult the system is at the moment. It's a reflection of just how great the volume is at the moment. And you know, I think that would break every GP's heart, you know, hearing stories of that, and we do hear stories of that in every single practice. The demand is huge. And you know, there's no other answer to it. I mean, we can be as clever as we can in terms of our working arrangements, but there's no other answer but capacity. We just need more capacity to enable general practice to do what it can and what it does best.
No, that's fair enough, Alan, and thanks very much for that. And just my final question then on the back of that, because I'm just thinking then practically, if we're in the scenario that the phone systems we already know won't cope for the winter period, what can we physically, practically do to help to support you as a committee? Because if we're in that situation, we need to get into solution mode, and I know the issues around workforce and MDTs are probably much longer term. So in the immediate term, what can we do to try and help you cope this winter? And in those scenarios where those phone calls are being made and not being answered, is there any process in place where someone is looking at this and overseeing it, and maybe even doing a courtesy call on the back of that to reassure patients that it's not intentional, you are just struggling?
Yeah. So again, and apologies, Laura, I'll answer first and then let you come in a second. In terms of what we can all do together, this is about public messaging. Lawrence has actually already mentioned about how we prioritise our calls, and I always divide it into want against need. And I think what you're referring to is we know that there is a cohort of patients that really, really need medical attention. We also know that we're getting waves and waves of patients who want. It is a want as opposed to a need, potentially. And what we all need to do is we need to make sure that we are dealing with the need, dealing with the people who most need that attention. And so there is a lot of public messaging, there is a lot of community messaging and so on in terms of supporting our practices to make sure that we can deliver to those that need it the most. Every single practice, and I know that mine is very good at this. If there are vulnerable people and they are struggling to get through on the phone, they will get us messages otherwise. And if somebody drops a handwritten note in saying, please phone Mrs. Smith down the road, we will deal with that and so on as well. So I'm not encouraging for a second that people start bypassing, but if we know that somebody is in real need, get us that message, get us that information, and we will deal with it, because that's our job. That's what we're here for.
Yeah, and then just to come in with Alan as well there, I mean, we really want to be delivering the service that we are all trained to do and that we're all committed to do, but it's just, sometimes it's too difficult. Big things that could really help, as Alan says, the public messaging is very important, and we've just finished Self-Care Week, which was last week, and a really important message to the public would be, really please try and help us if you can self-care. Obviously, if it's an emergency or some important medical thing, we want to hear from you, but if you can, there's really good resource. Community pharmacy have excellent support there. Many of their medications are free. There's really good support there. Online, there are also some really good websites, and so we would encourage, obviously, reputable ones like NHS and Patient Direct, and there's plenty of resource there as well. Investment into our surgeries, I mean, while we agree we can't make more GPs tomorrow, there are things that can be done for emergency winter urgent pressures. So as the winter pressures, as we've mentioned before, was very welcome, we're very open to for it to be increased, and yes, if department could, we would strongly encourage that they could increase it, not only to increase the amount of it, but also reduce some of the bureaucracy around it and allow us to employ different members of the team. Winter pressures has to show additionality in our surgeries, so it means that if we normally run 3 surgeries in the morning, we have a 4th one, and that's fine. That usually requires a GP, but if there could be a bit of flexibility which allows us to maybe use it for administration purposes, maybe another receptionist answer the phone, we would welcome that strongly. It would help us give better patient experience, or even nurses, trust our surgeries. Our surgeries are unique little environments, but they will know how to use that best. As I mentioned earlier, just in my introduction, the rescue plan, which is run by the Federation team, is under pressure at the moment. It had its funding reduced there at the start of the COVID, and it could really do with some support. This is a really good plan. So what it does, it goes and sees practices that are struggling, but it doesn't just put in resource, it puts in an action plan. So it sits down with them and sorts out a practical way for that practice to get back on their feet. It's not just a crutch forever. It's a strategic plan which would help that practice. So investment in the Federation run rescue plan, and I'm very happy to supply details with this afterwards. And then back into the digital investment. We need more digital investment. If practices could be contacted if they need more laptops to work from home, to work remotely, that would be greatly supported as well.
Thank you.
Thank you, Arlia. And Deborah?
I just want to thank you both for coming to the committee today. I think we could all talk about this issue all day long because we really want to be able to help our constituents, and likewise you want to be able to help the patients out there as well. And we know that from speaking to our constituents, it's such an important matter for them, and getting access to their GPs. I think maybe you could agree or disagree. there's more awareness around illnesses now, and so I thought it was an interesting point there that you said about, if in doubt, speak to your GP, and maybe taboo subjects, 20 years ago, people are now going to their GP, and that's a good thing, and we want to encourage that, obviously. But naturally the system and the workforce maybe isn't able to cope with the amount of people that is now trying to access their GP for a range of different illnesses. And I think we have to realise that our GPs and our health service has changed, and we need to change things as well going forward to make the service better for everybody, better for staff, for GPs, for receptionists, for the patients, everybody. I just want to ask around the GPs' practices and their staff. You touched there on a practice, and I'm just wondering, has there been figures of GPs leaving the workforce during this time? Why are they leaving? Is it retirement, stress, or redeployment? And you said there that no GP practices closed during the pandemic. That's really excellent. And I want to congratulate you, that has been the case. But do you expect with the winter pressures that we could see GP practices closing? Because I do know that they're under pressure. And I know that from my own constituency of Fermanagh and South Tyrone, we've real concerns over GP and retention, GP recruitment and retention. And have GP staff been able to avail of any leave during this time, and what steps are being taken to promote their well-being? A few more questions after that, but I just wondered if you could touch on that first, please.
Thank you, Leah. Those are excellent questions. So first of all, yeah, and despite Alan and I saying how difficult it is on the ground, we definitely want to hear from patients who have sinister or worrying symptoms. So if you have weight loss, if you have an unusual mass, if you have blood anywhere, obviously we want to see them in our surgeries and so on. It's very important, again, when we mentioned earlier about a change of how people think. So I would like people to think about their practice team. And this is going to be so important when we hear about MDTs as well, so that the whole team is there to support you on any of your concerns. And again, Alan and I urge this time and again, if you can advance a little bit of information about why you called to the reception staff, they are trained, highly skilled reception staff who can help you and help you get to the right person. They're trained, they're bound by the same rules of confidentiality as every other member of the team, but sometimes just a little bit of information can help them support you with that. But we're definitely here there for our patients. I don't have exact figures about GPs leaving, but we do know that 26% of our GPs are over the age of 55, and we're very worried about them retiring at age 60. That could be a massive dent in our workforce. It would be very hard to recover from that very quickly, so it's important that we act now, and appropriate workforce planning is put into place now. We would strongly encourage the department to do that. In terms of well-being, your point is very, very well made. It is vital that we have adequate support for well-being. We have a Dr. Rose McCullough, who is AMD in Southern Trust, is working actively at the moment at a support from all doctors who are suffering from mental health issues or issues with addiction. We already have an occupational health service, but if you appreciate these two services with mental health and addiction issues are things that GPs and all doctors don't like coming to their GPs. We live in a small society. It's difficult for us to go to normal doctors, but we think a specific service for these two things could really help retention and could really help support our workforce. So we would be very grateful for any support you could give us for this.
Yeah, and just to add to Lawrence's, and just on one particular part of that, is the numbers. We don't have accurate numbers. It's actually really difficult to get accurate numbers of GPs. Because everybody works in individual practices, and we've got a sessional contingent as well, although that has reduced. But the two ways that we lose our GPs is one through early retirement, and it is a reflection on a system that is wrong. That anyone who is 50 and above, even into their early 50s, is looking for how they get out, as opposed to how we retain them, and that has to be a big focus because we lose our GPs far too soon and far too early when there is many years left of good work in them. So there is a bit about retaining our GPs, but also then the younger GPs coming through, and by and large they tend not to work in the same patterns as our older and retiring GPs. So when Lawrence says the 26% that are 55 and above, those actually tend to be the ones that are working 9 or 10 sessions in general practice, whereas some of the younger GPs, and there's multiple reasons for it, work less than that. We just have to accept that. There's multiple different rules or multiple different reasons for that, and quite often they're doing other things as well. So they might be working in hospital clinics, in EDs, or they might be working in some of the federation clinics. And all of that we recognise is a good way to actually encourage them into general practice and to keep them in general practice as well. So we don't see that as a negative, we see that as a positive, because we're tending to get something across the whole system whilst maintaining them in general practice as well.
Okay, I'm going to have to move on
That's
now.
okay.
I'll come back
That's
if time
grand.
allows,
Yeah.
but for now I'm going to go to Jerry. Go ahead.
Thank you, Chair. And I hope, Lawrence, your daughter's okay if she's
Thanks, Jerry.
contracted COVID, and you as well in the family. Kind of following on from Marlea's question, but what tangible measures do you think could alleviate the pressure? And do you think the Minister is sufficiently engaged or taking them up? And just one other question. If you'd like to address the point suggested by some politicians that the pressure in A&Es is down to, some of it is down to the way the GP practices are set up. To me, that seems to be a deflection and a distraction from the real underfunding in our A&E and generally our health service. But if you'd like to comment on that and the first question, that would be great. Thank you.
Thanks very much, Jerry. And I think that's a very important point. I mean, we do get dispirited when we hear people saying that they've been in a hospital ward and people are lying on oxygen. If a patient is in a casualty department and they are relying on oxygen, they're too sick for Alan's surgery and my surgery. They're what we technically call a Category 3 patient, so they need to be in hospital. And unfortunately, there's nothing that Alan and I can do about that. They need to be in the right place to get the right care. So very keen to support you with that. But back to the immediate measures, I mean, they're the ones that we've outlined. Increasing our winter pressures would give us some immediate release, and reducing the bureaucracy of this to allow us to employ other members of our healthcare team. Increasing support for the rescue team, which is federation based, which is practical and will help support our practices, and then investment in our digital infrastructure. We think those three things could make an immediate impact and would be very welcome. Anything else there, Alan, you want to?
Yeah, I mean, again, just your second point, Jerry, is so important about pressures in ED. The pressures in ED are not with the minor cases coming through. We're both involved in the No More Silos project. We see the data, we see the figures all the time. It is about really, really sick patients who are needing admission, and it's actually the pressures in EDs are by and large caused by the flow through the hospital more than anything else. Now, having said that, and I referred to it in my opening remarks, a really strong and a really vibrant primary care can actually add so many more solutions to this. And we have examples, we have some really good examples of where the system can work well. And I'll give you one of them, which is the acute care at home or the hospital at home scheme, which is preventing a lot of our elderly patients going into hospital in the first place, attending ED. So they're seen by a multidisciplinary team led by a consultant in the community with either access to direct admission or rapid access to investigations whilst they remain in their own home. And that sort of team can also pick patients up on earlier discharge as well. So it is about, the solutions aren't about all investment in building bigger and bigger and bigger EDs. It's very much about that community and primary support that facilitates the flow and means that the patient is dealt with appropriately in the right place. And the right place very often is their own home. But we need to have the investment, we need to have the people, the staff and the investment where we want our patients to be and where we want our relatives to be.
And added to that, Alan, as well, sorry, Jerry, if you allow me, is building systems that allow us alternative routes for patients to be seen. So, for example, today I had a patient who has a significant chest infection. It's not settling with oral antibiotics. But frequently, the only place I would have had for him to go to would have been ED, which is obviously the wrong place. Daisy Hill, which is just one example, has a direct assessment unit, which has been a terrific addition. I get to speak to a consultant face-to-face who's able to see them directly and do the chest X-ray and appropriate bloods on that same day. So anything that can increase these ambulatory patient pathways that Alan and I have access to is really to be welcomed to. We need alternatives to emergency departments, which we have frequently not had previously.
Thank you, Jerry. Alan?
Thanks very much. Certainly, I've got a little football team and a subs bench of grandchildren, and of course, mums are always looking for reassurance about medical conditions. And I have to say that when they have consulted their practices recently, they have received that reassurance in a timely fashion. And when they've needed face-to-face, they've been offered that and facilitated on the same day. So the system, it is still delivering. In terms of the early retirement, I know personally a couple of GPs in their early 50s who took early retirement and are living now in sunny climes. But their reasons were the amount of admin that was been forced on them, and that they felt that they'd stopped actually being doctors, and it was eating into their downtime, just like headmasters have stopped being teachers. So I don't know how, if that is an issue that you identify and how that maybe can be addressed. I'm just wondering, what is the pathway into becoming a GP? Is it a choice you make before you go into medical school, or is it a choice you make when you come out of medical school? Does it require additional study and additional qualifications? And is there anything that we could do to make it more attractive for young doctors to choose the path of general practice, be it either financial or better retirement conditions or whatever? And just finally, the 230,000 weekly consultations that you spoke about, does that include the vaccinations that you're currently given, or is the vaccinations in addition to that number of consultations that you're delivering?
Can I start with that?
Yeah.
Is that okay? So if I start, so thanks very much, Alan. I really appreciate it, and I hope your grandchildren are okay. I mean, I know it's very difficult, so it is, but I hope they're fine. I mean, your points are really good. So first of all, from the admin point of view, we're very grateful that one of our big bits of administration, which is called Quality and Outcomes Framework, has been suspended until April. And again, I think this highlights how different we are here in Northern Ireland compared to the mainland. Alan and I speak to our colleagues across in the mainland, and the relationship we have here with government and so on is just night and day compared to the relationship back across the waters. So we're very grateful for that suspension at the moment. And Alan and his team will be discussing that further as it gets renewed coming up to April time. In terms of encouraging GPs or new doctors to become GPs, we work very hard on that, so we do. It takes, once a doctor has done their foundation training, that takes them 3 years. The Royal College of GPs would like that to be extended to 4 years. We think that they need longer in specialties and so on to make them even better GPs. And we will continue to discuss that with government and so on. It's really important, though, that your point talks about teaching. The role of teaching in general practice is massive, and we have a huge responsibility with it. So Queen's University has changed their curriculum to the new curriculum called C25. That new curriculum will see 25% of all undergraduate teaching coming into general practice. Now, this is for all doctors, not just general practitioners. Queen's has increased the number of students it takes, and we now also have a new university. So it is vital that general practice gets appropriate investment to help us teach these new doctors, who will be now taught in generalist skills. So the generalist skills is the new thing recognised by Health Education England, and it recommends that all doctors really should have better generalist skills. We think this is really important, and it's important to remember GPs, we are expert medical generalists. I know it sounds strange to be a specialist in a generalism, but as Alan will tell you, it is quite a specialty where we can take people and find out what is the most important things to them and what are the priorities with their clinical care. But yeah, we definitely need support to train the new doctors of tomorrow.
Thank you.
Will the current model, do you feel that it offers hope that you will be able to get the doctors that you require in the years ahead? Or does the current model need to be revisited?
Very briefly.
So it does need to be revisited, absolutely. So we have 111 training places to be GPs, and we would urge that this is reviewed. We will need this, reviewed, and I think there are plans to do that, but definitely we will need more. So we will need that 111 places reviewed.
Thank you. And then Carol, Nikhil, go ahead, Carol, please.
Sorry, there was just issues coming off mute there. So thank you, Lawrence, and thank you, Helen. And Lawrence, I hope your daughter and the rest of your family stay safe. So the facts are that there are more people attending A&E, and part of the reason is that they're saying they can't get through the GP. They've got bad chest and respiratory illnesses. And some have got mental health problems and other complications. But that's happening. So some trusts have urgent care centres as well as A&E, and others don't. What is the pathway that you spoke about? What additional pathways do we need to ensure that people don't go into A&E if they can't get through to their GP? And then the last question is this, because I'm aware we're pressed for time. Not every GP has access or offers like an info on a web page. I mean, I had a wee constituent who posted a lovely letter to their GP asking for a phone call, which is quaint, but it really shouldn't get to that. So it's just your thoughts on that, because in the Royal, for example, we had a situation recently where our out of hours was closed because we couldn't get cover. So the amount of people that went to the emergency department and the urgent care just was through the roof. So it's just to try and find out what additional pathways are needed to ensure that doesn't happen if people can't get access to their GP.
Okay,
thank you.
I'll pick up on that to begin with, and that's the start of a very long conversation in terms of an answer. But I'll try and be as succinct as possible, because you've actually picked up on exactly the right points, Carol. Because our emergency departments are emergency departments. They should be there for emergencies only. And what we should be doing is investing in services that sit outside of emergency departments. You've already mentioned the urgent care centres, which are showing some very early success and diverting people away from the emergency department. COVID actually dictated that we co-located those with emergency departments. But I think the future model has to be that we've urgent care centres that are sited in the communities outside of the hospital environment, staffed in combination between secondary and primary care, involving multidisciplinary teams as well. So patients are managed in an out-of-hospital environment, and that then starts to pick up the out-of-hours question as well, because you would run your urgent care centre into the out-of-hours environment. So I think that is very much the model that we need to strive for moving forwards. And again, if we fall into the trap of building more emergency departments or bigger and bigger emergency departments, then we're going to be failing, and we're going to be doing what has actually created so many of the problems that we now have. And you again very cleverly, and I suspect entirely intentionally, use the word pathways, because this is about getting the right pathways. It's about knowing what's wrong with the patient early, knowing what needs to be done, and then accessing that correct pathway, which shouldn't always look like an emergency department as the first point of entry to the hospital, because so many other alternatives are available to us. But this involves whole system. This isn't just a question for general practice. It is a whole system change. No more silos. The project No More Silos is starting to address that, and it really does need to be accelerated, and we need to achieve what we know that we can achieve with it.
Okay, thank you, and thank you both for what has been a very useful, if pressurised time-wise session. I think just in terms of the timing of where we're at, I absolutely agree actually with a lot of what's been said around the urgent care centres, around the need to really crack this issue of primary care and getting proper care and the multidisciplinary care out into the communities to keep people at home. I actually started off last week's meeting with a glowing reference for acute care at home in the Southern Trust area. And I wanted to reflect one of those positive stories and what are so many negatives. But I think that model of care in terms of health, mental health, well-being, support, independence, all of those things are better supported the earlier and the closer to people's homes we can get that care. So listen, that's all a lot of work to be done in that respect. But I want on behalf of the committee to thank you both very much for attending. Lawrence, please pass on your best wishes to your daughter, and I hope that everyone is okay in that sense. And to wish you both all the very best, and the entire cohort of GPs who we understand are struggling and who we understand are providing a service as best they can in a very, very pressurised situation. So, Gorma Agat, Marshin, August Chief Shiv, thank you, and we'll see you again soon. Thank you.
Thank you so much. Thank you very much. Thank you.
And members, that just leaves time, date and place of our next meeting, which will be on Thursday, on the 25th of November, coming in the Senate chamber at 9:30. Thank you.
This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly